Well, good afternoon, everyone, and thank you so much, Professor Satischandra, for that very warm introduction and for the wonderful hospitality and collegiality that you and your colleagues have shown to us over the last few days in Bangalore. I'm not going to talk about genetics now, but I will address that in the oration. But rather, I'm going to talk about some practical aspects of the management of epilepsy. I'll be dealing largely with diagnostic aspects, and Dr. Pedley, who will be following, will talk more specifically about some of the drug treatment aspects. So what I want to highlight are some of the relatively newer areas, and I'm going to address the subjects as listed there, with the exception of the therapeutics, which Professor Pedley will deal with. So, as you know, epilepsy affects at least 3% of the population at some time in life, and sadly there is still a lot of stigma and prejudice around it. That's true in Australia, and I've learnt that it's certainly true in India. And as much as treating the medical aspects of epilepsy, we as physicians and medical medical professionals have really got an obligation to deal with that as well. Epilepsy is not a unitary disorder. We divide the seizures up into what are generalised and focal types. That represents a fundamental biological distinction. Generalised seizures begin simultaneously on both sides of the brain and are usually due to genetic factors, whereas focal epilepsy arises from a localised part of the brain, particularly the frontal and temporal lobes, and can be due to both acquired and inherited causes. The physiology is different, as we can study in the laboratory and indeed in man. And each major category has a number of subsyndromes with different etiologies, prognoses and treatment. I tell my students that if they're diagnosing epilepsy, they're not doing their job. That's no longer sufficient for proper management of people with epilepsy. And we need to go through a sequential process of diagnosing the type or types of seizures the patient has, and there's a new and evolving classification for that, and then to diagnose them with the particular type of epilepsy that they have, because the epilepsy is the disease or disorder that determines the prognosis and the treatment. It's not good enough just to treat symptoms. If we treat indigestion, we don't know whether we're treating reflux, gastric cancer, or some other GI problem. Similarly, if we're treating a seizure, a grand mal seizure, which is not a term we like, it can be due to any number of things. And we need to be specific in our diagnosis, and I'll give you some hints to that. So first of all, the seizures, which are the symptoms, and the diagnosis here is largely made clinically, and where there are difficult cases, it's supplanted with the routine EEG, and where there are difficult cases, it's solved by monitoring. And as I said, there's a broad distinction of focal and generalised seizures. The terminology has changed. It's been a controversial area. Some of the words didn't quite mean what they were meant to mean. The focal seizures are broadly divided up into three types. Auras, which you're all familiar with, which used to be called simple partial seizures, but that created a lot of confusion, and they are now called focal aware seizures. Complex partial seizures also went by a variety of names in the past, psychomotor seizures, and these are now called focal unaware seizures. I can talk about the reasons for the change, but this is the terminology that's now been recommended. And then they may evolve to bilateral convulsive seizures. And that represents a sequence of spread of the epileptic discharge, beginning in one place and then spreading more widely. The classification of generalised seizures is more or less unchanged, and the common types we see in adults are tonic-clonic seizures, absence seizures and myoclonic seizures, whereas the last three are broadly confined to the severe epilepsies of childhood. And then we acknowledge that there are some seizures where we don't actually understand their fundamental physiology, the best of which is epileptic spasms, which can occur in patients that have got a focal lesion, but certainly can occur in patients with a diffuse generalised disorder as well. And it is a special disorder largely confined to the infantile period, but not exclusively so. So they're the symptoms. Now, what about the syndromes? In every other area of medicine, we describe the disorders or syndromes, and this has been something that's been slow to develop, particularly in the English-speaking world. Although I think the Europeans were somewhat ahead of us in this. And these syndromes are defined by characteristic seizure patterns, usually with a specific age of onset, often with a typical EEG pattern and sometimes with a known cause. And as I said already, that allows you to give an accurate prognosis. There is no such thing as the prognosis of a tonic-clonic seizure of an absence seizure, but there is a prognosis for juvenile myoclonic epilepsy or temporal lobe epilepsy, etc. More than that, it allows us to give proper counselling and, very importantly, anticipate the psychosocial difficulties and hopefully prevent them, and then design the treatment to the particular disorder. There is also some advances in the terminology for the causation of epilepsies. We used to speak about idiopathic epilepsies, which was a term that some people still love, but is one that's very confusing. The decision has been made to discard it, and symptomatic, which also can be confusing, and we now try to describe the syndromes by their etiology, be it genetic, structural, metabolic, immune or unknown. And I'll talk a little bit about the immune epilepsies because that's quite new now. And some syndromes, for example, temporal lobe epilepsy, can fit into more than one category. Some patients with temporal lobe epilepsy are familial and are genetic, and sometimes we know the genes, most often not. You can have it due to a temporal lobe tumour or benign developmental lesion, and you can also have it from immune causes and even unknown. So this allows us to really accurately finesse the diagnosis of the patient. So I don't have time to go through all the epilepsy syndromes, and that's really something more for the sort of epileptologist, but just to give you some examples of how this works. Childhood absence epilepsy, this is classical petit mal, the 6-year-old child who's perfectly normal and starts having what are thought to be daydreaming spells in school, off and on, 100 times a day. And then the diagnosis of epilepsy is made. And why is it important to diagnose that as childhood absence epilepsy? Well, we have specific treatments for that Dr. Pedley will no doubt address, and it's got a specific prognosis. The absences nearly always stop. It may be associated with tonic-clonic seizures in adolescence, and it nearly always, not always, but usually resolves in adult life. Another form of generalised epilepsy is juvenile myoclonic epilepsy. This begins in teenagers and is characterised by myoclonic jerks, particularly in the morning, and particularly exacerbated by sleep deprivation and alcohol. And recognition of this is important because whilst the drugs are important in this disorder, even more important is the lifestyle counselling. And you've got to convince the patient that they need to do what their mother told them, that they can't stay up late at night, they can't be, they've got to be careful with alcohol, and they can't use drugs. And of course the 17-year-old male doesn't want to hear that from you, but that's part of the school of doctoring, to try and educate them and try and win them over, and then the management is better, they get their licence and they get on with life. They're the sort of milder causes of generalised epilepsy, and in some of the severe, the paradigmatic severe form of generalised epilepsy is Lennox-Gastaut syndrome, which is crash helmet epilepsy, the unfortunate children who start having tonic and atonic falling attacks, typically in the kindergarten sort of age group. I've already mentioned temporal lobe epilepsy, which has a number of causes, some benign and some very difficult to treat. Temporal lobe epilepsy forms the largest portion of our surgical series in general as a form of focal epilepsy, but on the other hand, there's a very mild form of focal epilepsy which is very common, called benign Rolandic epilepsy, or epilepsy of childhood with centrotemporal spikes, and this is the 9-year-old child who starts having attacks at night or has a seizure falling asleep in the back of the car after the long drive on Sunday. Very much sleep related. They can have quite alarming attacks. But why it's important to diagnose this is that it almost always resolves within 2 years, and although the parents will be extremely anxious about it, you can be very reassuring about a good prognosis and lack of seizures persisting into late adolescence or adult life. So that's what I hope will give you a feel about why it's important to get the diagnosis right and to push it as hard as you can to give the patient and the family the best information. Now let's talk a little bit about the epidemiology of epilepsy. We all know, and we always knew, that epilepsy was particularly common at the start of life, from the neonatal period into early childhood, and in fact in some countries it was euphemistically known as the children's disease. Of course it can begin at any age, but what we've learnt now is that there's actually a second peak in the elderly. This has been seen in virtually every country where it's been looked at hard. We'll hear from Professor Mathias about the challenges of diagnosing fits and falls in patients. It can be even more challenging in the in the elderly, where there's all sorts of comorbidities and lots of reasons for falls, etc. But it's clear that there is a peak of new onset epilepsy in the elderly. I think this is a very important and under-researched area. Everything in the elderly is put down to cerebrovascular disease and degenerative disease, and there's no doubt that stroke and degenerative diseases like Alzheimer's and frontotemporal dementia can cause seizures. But certainly the data and my experience suggests many of these cases, the evidence for those processes is actually pretty modest, and I don't think we really understand the full spectrum of the causation and indeed the treatment of epilepsy in the elderly, which is something, as our population ages, is an increasing problem. So how common is epilepsy? Well, I've shown you the sort of bimodal curve of the incidence. Overall, there are about 70 new cases per 100,000 per year, and that's remarkably uniform around the world. In some places where there is a particularly specific cause, for example, cysticercosis in this country, it may be just a little bit higher. And the prevalence, that is the number of active cases, is about 0.5%, or 1 in 200 individuals. And overall, about 8% of the population will have one or more seizures in life. So it's something that, every family will encounter. One issue that I'm very interested in is the new onset epilepsy. Our view is that if you get epilepsy at the beginning and you treat it properly, you probably improve the prognosis, and you certainly help in terms of getting the psychosocial issues right and guiding them through the very difficult issues in adolescents or adults about driving and occupation, etc. So the first thing to say, and I'll emphasise this again, many people that are presented with their first seizure don't actually have epilepsy, and we'll hear more about this from Professor Mathias. And whilst it's a crime to underdiagnose epilepsy, it's a greater crime to overdiagnose it. If you diagnose somebody with epilepsy and they don't have it, you've done them an enormous medical disservice. You put them on drugs that they don't need and will cause side effects. You've put them off the road. You've told them that they can't go on to that particular occupation. They may be giving wrong advice about partnering and marriage. So it's really important to get it right. The second thing is that in our experience, and I think those of others, the patient presenting with his or her first seizure to the emergency room, it's often not the first. It might well be the first major convulsion, although patients don't always present with the first major convulsion. But one of the clinical subtleties and one of the important things is to probe them very carefully for subtle symptoms. Myoclonus in the case of somebody with suspected generalised epilepsy. Subtle auras, prolonged déjà vus, funny feelings that patients think are normal. And if they're asked those questions, then it helps you figure out the diagnosis. EEG is particularly valuable at the beginning, and EEG, in many places used to be regarded as sort of a backroom type thing that you did it kind of when whenever, and it's hard to say that in front of Professor Pedley, who's written the authoritative book on EEG, but I'm sure he would agree that in many cases it's badly used. Where it's useful was particularly useful is early on. It's sort of a frontline thing. You get the EEG done, the frequency of abnormalities is higher early on, and you help the patient considerably. And depending on the age group, imaging is really quite important. CT scan is useful for some types of epilepsy. It's more useful in this country than in other countries because of the cysticercosis issue, but epilepsy is by and large a disease of the cerebral cortex, and the cerebral cortex is badly imaged by CT because of the overlying bone. So you need to do MRI, which is, of course, can be a resource issue. It used to be a big resource issue everywhere, but certainly in the first world it's now readily available, and it's becoming more available around the world as well, and it's a far superior investigation in epilepsy. So you've diagnosed them with the first seizure. We'll come back to some other diagnostic issues in a second. Do you treat the first seizure? And Professor Pedley will probably address this as well. My view, often gets asked this, but that's the wrong question. You need to assess the epileptology, the whole question. What syndrome does the patient have, if you can figure it out? You know, is there an imaging abnormality? Were there provocative factors? If this first one occurred in the setting of extreme sleep deprivation with lots of alcohol, etc., there's nothing else to find, then probably the chance of recurrence is lower than when it occurred out of a sort of a clear blue sky. Secondly, the psychosocial aspects, particularly in children. In the community that I treat, when I see parents where their child's had the first seizure, there are two polarised responses. First, I never want to see that happen to my child again. And second, doctor, there's no way I'm going to give drugs to my child. And you've got to negotiate between those depending on the syndrome and try and give the best advice. And of course, the patient is always right. I'll leave status. I want to mention sudden unexpected death in epilepsy because this is a problem that we're becoming increasingly aware of. Not that it's becoming more common, but it's something that is being brought more to our attention. We've all known for years that every year there are patients that don't come back to our clinic, and we kind of put that in the back of our head, and sadly some of them die. And it's not necessarily known to us unless the family rings us up. And this problem of sudden unexpected death in epilepsy has really forced to the medical profession's attention by some of the lay support groups, and I think the profession was really very lax in getting to that, and I certainly count myself amongst that. And the problem is that it's not that rare. If we think about sudden death, we all know that we can drop dead suddenly. For young adults in the general population, it's about 1 in 20,000 person years. In the elderly, as you'd expect, it's somewhat higher. In the general population with epilepsy, it's about 1 in 500 to 1 in 1,000. And in patients with severe epilepsy, it's 1 in 200. So with 200 patients that you see with epilepsy in sort of an epilepsy clinic, severe epilepsy, one will drop dead each year of this. And in some series, in some institutionalised people with very severe epilepsy, it's as high as 1 in 100 or 1%. Its mechanism is still disputed. More is being learned about it. It's a very difficult thing to research, but it does seem like there is... it's probably not a cardiac... Well, first of all, the mechanisms may be heterogeneous. It's probably not asystole as the initiating event. It's probably it's probably respiratory, and it's probably driven by brain mechanisms that we don't yet understand. But from something that nothing was done about, there is now very, very active research to try and prevent it. And we're now advised to raise this with our patients with epilepsy. First of all, it's clear that tonic-clonic seizures are a risk factor for this, and non-compliance is a risk factor. So whilst not wanting to sort of use a carrot and stick approach, it's something that should be brought in gently into the conversation. That's a very good reason for compliance. And sleeping alone is probably a risk, and that's a difficult issue to deal with, but certainly even when after a seizure, if patients sort of stop breathing, it appears that even just gentle sort of stirring of them may prevent this, and that's obviously a challenging thing to work out depending on the patient's social circumstances. So let's come back to the patient and the diagnosis. So I go through a sort of three-stage diagnostic process when I'm seeing somebody with epilepsy, or when I'm seeing somebody who is poorly controlled. I ask, first of all, do they have epileptic seizures at all, or is it something else? Secondly, I ask what type of seizures are occurring, focal or generalised. And third, I ask what syndrome is present. Now, here's a seizure. This is a reasonably famous video. Some of you may have seen it already. But for those that haven't, I'd just like you to tell me what type of seizure this is. Sound doesn't seem to be on. Do you? Okay. I'll just play it again because it's there's a few clues in the sound.
Migraines could manifest itself in high-frequency bursts.
10 mal von 1 bis 10. 10 mal von 1 bis 10. 10 mal von 1 bis 10.
Who'd like to suggest what type of attack this was? You have to shout out loud. Sorry? A myoclonic seizure? Myoclonic seizure? Okay. Anybody else got any other suggestions? Sorry? What sort of non-epileptic? There was shaking and twitching and the patient's unconscious?
There seemed to be some audio sort of vocal trigger. Something was being said. I don't know if it's a religious conversion experience.
So are you suggesting it's psychogenic?
It could be psychogenic.
Okay,
it could
so
also be frontal.
We've got myoclonic, could be frontal. Okay, any other suggestions? I'm sorry? Generalised tonic-clonic seizure. They'd generally be a lot longer. So let me show you another one of the same thing where it's actually explained a bit more. This is the commonest misdiagnosis of epilepsy. If you remember one thing from my lecture, I want you to remember this.
Hyperventilation while squatting, rapid rising under the valvular maneuver.
10 mal von 1 bis 10. 10 mal von 1 bis 10.
In order to test the responsiveness, subjects are repeatedly asked to count.
10 mal von 1 bis 10.
Does anyone want to revise their diagnosis? Okay. So this is syncope. This is fainting. This is not epilepsy. If you haven't seen this, you've not taken enough blood samples. The pathology nurses see this all the time. This was an experiment done by a German group to actually document the features of convulsive syncope. So what's really important when you faint, and particularly if you're prevented from falling, or if the stimulus is great, you know, syncope in a phone booth or syncope in a mosh pit where people are squashed together, one can go stiff and one can twitch. So there are myoclonic jerks, but then it's not epileptic myoclonus. So this is syncope. It is not an epileptic phenomenon. The recovery is fast, and if you treat this with anti-epileptic drugs, you are doing your patient an enormous disservice. And this happens all the time in my country, and I suspect in this country. And the clues are not so much, you obviously don't have the benefit of a video in most consultations, but it's important that physicians see this so you can understand that people can stiffen and twitch with syncope. And the answer is not in the main event, it's in the prologue and the epilogue. So in other words, what happened before, and that it's a sort of syncope-inducing situation, it's an emotional situation, it's a very hot room, and at the end, the recovery from syncope is usually rapid. After a tonic-clonic seizure, the patient gets up in the morning, has an event at the breakfast table. If it's a tonic-clonic seizure, the next thing they remember is being in the hospital. If it's syncope, they remember their family and the ambulance people coming around them and waking up and just missing a short bit of time, unless they hit their head on the way down and get concussed as well. So that's really important for sort of practical management issues. So once you're sure that they have epilepsy and hopefully have figured out the type of seizures and syndrome, it's very important to educate people about this. Particularly with the stigma and mythology about epilepsy, you need to educate them and demystify. You need to explore psychological factors, and we'll hear a lot more about that from Krish. And very importantly, you need to give them lifestyle advice. What restrictions on activity should they have? What's the problem with people with epilepsy having a shower? What injury happens in a shower? They get burnt. And why do they get burnt? At least the showers in my country, you turn the hot water tap on to try and get things going, you wait till it's warm and then you turn the cold off. Every year our burns unit sees people having a seizure in the morning, they get propelled in the shower, they're on the shower floor and they get burnt from the scalding water. Why do people with epilepsy need to be careful in the bath? Loud, I can't hear. They can drown in the postictal phase. So, you know, depending on how active their epilepsy is, and obviously supervision of people, particularly adults, is a sensitive issue. But you need to give them advice about that. Sleep is the most important thing in terms of life hygiene, the right amount of sleep at the right time each night. And extreme care with alcohol, and then certainly in adolescent and adult practice, the issue of driving comes up, and I'm sure the rules are slightly different here, so I won't pretend to teach you about that. How am I going for time, Satish? I'm worried. Okay, so look, I might leave the pregnancy thing and just talk about one sort of new area of diagnosis. We used to regard the brain as an immune privileged area, and to some extent it is, but we didn't think autoimmunity had much role in epilepsy. There is a rare condition called Rasmussen's encephalitis that we've known for years, which is really something just the paediatric epileptologists need to deal with. We also know that ACTH and steroids are effective in some of the nasty childhood epilepsies, but important for adult and indeed paediatric practice has been the recognition of a new family of autoimmune limbic encephalopathies. And these are really quite bizarre. The two commonest ones are due to an antibody against a complex that has a potassium channel and also a protein called LGI1, and another one that's directed at NMDA, which is one of the glutamate receptors. NMDA often in young women who may have a teratoma, and the LGI1 more often in an older male, and they can present to the neurologist, to the emergency room, to the psychiatrist. And they have a limbic encephalitis where they have a very peculiar pattern of seizures affecting the face and the arm. There can be many of these in a day, and sometimes it's thought not to be epileptic. And they can be quite encephalopathic. Some of them present with a psychosis, and epilepsy may not even be suspected. And some present with status epilepticus. So look, I might leave it at there because I think we started a bit late and I don't want to go into the time of the other speakers, but we'll take questions at the end. Thank you very much.
Thank you. Mimic